Next is Dr. Srinidhi PK, free paper 39.
A fine good afternoon all. Today my topic is changes in macular thickness following PRP for diabetic retinopathy. Coming to introduction, diabetes mellitus remain one of the most prevalent and important non-infectious causes of morbidity and mortality worldwide. Diabetic retinopathy represents microvascular end organ damage as a result of diabetes and ranges from non-proliferative diabetic retinopathy and its stages to proliferative diabetic retinopathy. Proliferative diabetic retinopathy affects about 5 to 10% of diabetic population. Panretinal photocoagulation is considered as the gold standard treatment of PDR after several studies. Coming to the objective of my study, to study changes in macular thickness following PRP in patients with PDR without clinically significant macular edema to get an additional insight to laser therapy in our setting. Coming to methodology, it is a prospective study conducted in Department of Ophthalmology, Government Medical College, Kottayam for a period of 1 year and included total of 120 eyes. Coming to inclusion criteria, all patients diagnosed with the PDR who were advised to PRP. Then coming to exclusion, diabetic retinopathy with the CSME on 90D slit lamp biomicroscopy examination. Then diabetic retinopathy with the central macular thickness more than 300 microns on OCT. Then patients with the other retinal vascular disorders. Then history of intravitreal drug use in last 4 months. Coming to study procedure, patients satisfying inclusion and exclusion criteria were selected. For all cases, central macular thickness and morphology was measured by OCT. Then PRP was done with frequency double ND-YAG lasers according to standard protocol. Each session was carried out in each eye in 3 to 4 sittings and completed over a period of 4 to 6 weeks. Then macular thickness and morphology by SD-OCT was again done at 1 month, 3 months and 6 months after completion of PRP. Then coming to results, the mean age of population was 50 years with a standard deviation of 7.75 years. Then coming to the diagnosis part, 96 eyes were diagnosed with non-high risk proliferative diabetic retinopathy and 24 eyes with high risk PDR. Then coming to the distribution of study population based on total number of burns, 96 eyes were given a total number of burns in the range of 1200 to 1600 and 24 eyes in the range of more than 1600. Then coming to mean central foveal thickness before and after treatment, here we can see in all treatment group, initially in pre-treatment group, the mean central foveal thickness was 224, which is increased to 240 after 1 month and it decreased to 232 after 3 months and again decreased to 225 after 6 month follow-up. Then coming to OCT morphological features, in majority of patients OCT morphology was normal followed by spongiform edema. Then coming to discussion, there was no statistically significant difference in central macular thickness between pre-treatment level and at 6 months from my study. In a study conducted by Mustafa Said Ahmed et al. For the assessment of effect of panretinal photocoagulation on macular thickness in eyes with proliferative diabetic retinopathy without clinically significant macular edema, it was shown that the post-laser macular thickness increased at 3 months, which was statistically significant and correlated with my study. Then coming to conclusion, the study concluded that PRP may cause a temporary increase in macular thickness in patients undergoing treatment for diabetic retinopathy. A well-done PRP reduces VEGF concentration in vitreous and in around 3 months offsets the macular edema induced by PRP in initial weeks. PRP by itself can aggravate a VMD or induce it in patients with a strong vitreomacular adhesion. Coming to recommendation, concurrent use of anti-VEGF along with the initiation of PRP should be judiciously considered for patients with PDR and macular edema, especially in Indian scenario where most patients can't afford multiple anti-VEGF injection. The potential benefits of anti-VEGF injection should always be weighed in patients with PDR and vitreomacular adhesions, as both intravitreal injections and PRP can exacerbate VMD. These are my references. Thank you.
Why did you exclude plus 90 diopter lens investigation?
What, sir?
You have excluded no plus 90 diopter biomicroscopy.
Clinically significant macular edema cases were
You have
excluded.
excluded. Why? Any reason for that?
We are not including.
No, you have excluded.
Yeah, sir.
Why?
We are taking only patients with no significant macular edema cases. That's why.
You want to show that PRP also can cause little bit of macular edema and then
Yeah, sir. It again decreased to pre-treatment level.
but what if the patient develops a CME also?
In that cases, those patients who developed macular edema, we had to exclude from the study and advised for intravitreal anti-VEGF.
Injection is still 4 to 6 weeks.
4 to 6 weeks, sir.
One is due to the laser they can develop a macular thickening.
Sir.
They may develop a CME also. You need to have a longer follow-up also to say whether it's a CME developing CME or due to the laser. Good. Thank you.